Acute abdominal pain. Visceral pain is vague in onset and in localization. There is a dull sensation in the midline. It could be in the epigastrium, periumbilical area, or in the hypogastric area. Splanchnic nerves innervate all layers of the intestinal wall, the serosa, and the mesentery. And they are mostly unmyelinated C fibers, and there are a few A delta fibers as well. There are four types of splanchnic nerves. There are chemonociceptors in the mucosa, tonic mechanoreceptors, which are a wide range of receptors, and they are called wide range receptors. High threshold mechanoreceptors, which are phasic receptors, and they respond only to a marked distension. And then there are silent nociceptors, which are activated only in the presence of inflammatory mediators. Why is visceral pain poorly localized? Splanchnic afferents spread across a broad range of dorsal root ganglia. They enter the spinal cord bilaterally. Afferent fibers to cell body ratio is low. And there is convergence between visceral afferents and somatic pain neurons in the dorsal neuron. This causes referred pain as well. Visceral pain is due to stretch or distension, and therefore gaseous distension in the colonoscopy gives more pain than a polypectomy. Somatic or parietal pain is a sharp, well-localized pain mediated by A delta fibers to the skin and the muscle. Involuntary guarding is mediated by spinal reflex arcs. The SOFA score, this is a sequential organ failure score. It's from 1 to 4, and the features that are listed are brain, lungs, kidneys, liver, and coagulation. So in brain, GCS would be 13 to 14, 10 to 12, 6 to 9, and less than 6 for a score of 4. Lungs, the PF ratio, less than 400, less than 300, less than 200, and less than 100. For the kidneys, the creatinine value of 1.2 to 1.9, 2 to 3.4, 3.5 to 4.9, and more than 5. And the liver, bilirubin 1.2 to 1.9, 2 to 5.9, 6 to 11.9, and more than 12. And coagulation, which is the platelet count, less than 150, less than 100, less than 50,000, and less than 20,000. Sepsis is suspected if the SOFA score is more than 2 and there is abdominal pain. And septic shock is present when the SOFA score is more than 2, plus a lactate of more than 2, plus vasopressors are needed in the presence of an infection. The types of pain a patient can have in acute abdomen. If you notice the A curve, the green one, it starts, then it subsides spontaneously with time. Example, in acute gastroenteritis. B curve, it is a colicky pain, comes and goes, progresses, remits, and then it can get worse. Example in renal colic, biliary colic, and small bowel obstruction. C curve, this one starts small and then it goes on progressing, and there's a linear line upward. That's gradual onset and progressive in any form of inflammation like appendicitis, cholecystitis, and diverticulitis. The D curve is a sudden catastrophic onset, and that's right in the beginning. Example, ruptured abdominal aortic aneurysm, ruptured ectopic, perforated viscous like a perforated duodenal ulcer, mesenteric infarction. The examination of the abdomen. Inspection, we check for fullness, we check for varices, we check the hernial sites, which is very important to check because it could be a strangulated hernia. We check for scars. We check for periumbilical discoloration, which is a colorant sign in hemorrhagic pancreatitis, and the flank discoloration. If there's a bluish discoloration in the flanks, that's called gray Turner sign, also in hemorrhagic pancreatitis. After inspection, we ideally check for bowel sounds before palpating the abdomen. And bowel sounds, if they are high-pitched and if they are churning bowel sounds, it suggests a mechanical small bowel obstruction. If they are hollow sounds, it could be a toxic megacolon. Sounds like a dripping in a cavern. On palpation, you check for tenderness. You do the tendermost area last. We check for rebound tenderness, any masses, fluid, and of course we do a rectal pelvic examination, which is necessary for all cases of an acute abdomen. Alvarado score to predict acute appendicitis. History, examination, and labs. In the history, pain migration is given 1 point, nausea 1 point, anorexia 1 point. In examination, right lower quadrant tenderness is given 2 points. Rebound tenderness 1 point, and increase in temperature 1 point. Labs, an increase in WBC count is given 2 points, and a left shift of the WBC is given 1 point. The total score is 10. Less than 4 makes it unlikely. More than or equal to 5 is suggestive of acute appendicitis, and if it's 9 to 10, it makes it highly likely. If the temperature in a patient with acute appendicitis is high grade, we suspect a rupture and an abscess. Otherwise, it's usually low grade fever. Scans that we do. Ultrasound scan has an 80% sensitivity and specificity for acute appendicitis. CT scan is done only if the ultrasound cannot pick it up. And this has a 95% sensitivity and specificity. Of course, for pregnant women, we can't do it. We do an MRI. The signs on a CT scan are appendix more than 10 millimeter diameter, periappendicular fat stranding, fluid in the right iliac fossa, and failure of the contrast to fill the appendix. 50% of infants with an acute appendicitis perforate compared to 10% of adults. Biliary pain. This is a constant night pain which is in the right upper quadrant or in the epigastrium and radiates to the subscapular area. It's postprandial. It lasts usually less than 6 hours. But in an acute cholecystitis, it's similar pain, but it lasts more than 6 hours. Due to this pain occurs because of the obstruction of the cystic duct by the gallstones. An ultrasound is 85% specific and 73% sensitive for gallbladder stones. Charcot's triad for cholangitis is fever, pain, and jaundice. The treatment for cholangitis is a CBD stent and antibiotics. The Tokyo criteria for acute cholecystitis is A, local signs, B, systemic signs. The local signs are Murphy's positive, right upper quadrant mass or tenderness or pain. And B, systemic signs are fever, increased CRP, increased WBC. And third one is imaging suggestive of cholecystitis. That is, sorry, not 3, it's C. The definitive diagnosis is 1A plus 1B, one of the A and one of the B, or C with a clinical suspicion of cholecystitis. Acute diverticulitis. 80% of people are more than 50 years old. They have left lower quadrant pain, tenderness, fever plus or minus mass. CT grading is by Hinchey grading. You have 1, 2, 3, and 4. 1 is localized pericolic abscess or inflammation. The treatment is just IV antibiotics in the hospital. 2, there is a pelvic or intra-abdominal or retroperitoneal abscess, and this needs drainage plus antibiotics. Hinchey grade 3 is generalized purulent peritonitis, and 4 is generalized feculent peritonitis, and both of these need emergency surgery. Acute mesenteric ischemia, there is, it's either a thrombosis or an embolism. Embolic occlusion of the SMA is more often seen than an IMA or celiac. This is due to the less acute angle at the origin. The SMA has a less acute origin than the other vessels. Primary thrombosis in 68% of cases, No-me, which is non-occlusive mesenteric ischemia, seen in 10% cases, and the mortality in acute mesenteric ischemia is 50 to 100%. The hallmark is an abrupt onset of intense cramping, epigastric or periumbilical pain, which is out of proportion to the exam findings. Patient will be in shock 25% of the time. The best test is a CT angiography. ACS, which is abdominal compartment syndrome, is another cause of acute abdomen. The normal intraperitoneal pressure is 5 to 7 millimeters of mercury. ACS is present if the intra-abdominal pressure is more than 12 millimeters of mercury. That's called intra-abdominal hypertension, IAH. Primary is due to a pathology in the peritoneal cavity. Secondary, example in pancreatitis, secondary is due to a massive bowel wall edema as in shock. And tertiary is a recurrent ACS. This is due to overzealous wound closure after treatment of primary or secondary. We measure intra-abdominal pressure by connecting a transducer to the Foley's catheter, and 0 reference point would be at the mid-axillary line in a supine patient. The grading of IAH would be normal less than 12, 1 12 to 15, 2 16 to 20, 3 21 to 25, and 4, that is very high in IAH, is more than 25 millimeters of mercury. Extra-abdominal causes of pain. Cardiac causes are MI and myocarditis, and of course pericarditis. Thoracic causes would be empyema, a pneumothorax, pulmonary embolism, Beer-Haft syndrome, esophagitis. Hematological causes could be sickle cell disease, HSP. Metabolic causes are Addison's disease, diabetic ketoacidosis, porphyria, lead poisoning. Infectious causes like zoster and osteomyelitis. Neurological causes, which are radiculopathy, abdominal epilepsy, abdominal migraine. Miscellaneous causes like narcotic withdrawal. In an HIV-positive patient and a post-transplant patient, the possibilities for an acute abdomen are drug-induced pancreatitis, neutropenic enterocolitis, CMV colitis, perforation, TB enteritis, GVHD, pneumatosis intestinalis, primary peritonitis.